Disorders of aging and cognition, drawing a line between issues related to aging and disorders of cognition. Geropsychology. As of 2014, according to the Centers for Disease Control, about 13.6% of the U.S. population is considered old, i.e. over the age of 65, as cited in Comer 2015. Erickson labeled the struggle at this age of life as integrity versus despair. What sort of attitudes and activities can the elderly adopt to increase the likelihood they'll enter late adulthood with a sense of integrity? What are some of the common stressors elderly populations face? What can be done to lessen the negative effects of these stressors? Risk and complications. Depression is common among the elderly, but no more common than among the general population. With the exception of elderly populations living in nursing homes, depression can raise the risk of other health issues. It is frequently linked to suicide at this stage of life. Generalized anxiety disorder affects 7% of the elderly. Though that number increases as we look at older age groups, anxiety issues are often connected to concerns about declining health. Continued. Substance abuse issues actually tend to decrease, primarily in cases where there has been a history of alcohol abuse. However, we do often see issues with prescription medications. Why might this be? Evidence points to over-medication in nursing homes. Some research shows that as many as 30% of nursing home patients are being prescribed antipsychotics despite failing to show any psychotic symptoms. What would account for the broad misuse of the particular classification of their drug? So we have the criteria here for delirium. A disturbance in attention and awareness. The disturbance develops over a short period of time, represents a change from baseline at attention and awareness, and tends to fluctuate in severity during the course of a day. An additional disturbance in cognition, i.e. memory deficient. The disturbance in A and C are not better explained by another pre-existing, established, or evolving neurocognition disorder. Evidence that it is due to another medical condition or the effects of a substance which might be clearly specified. Major neurocognition disorder. A. Evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains. So complex attention, executive function, learning and memory, language, perceptual, motor, or social cognition based on, so it's a loss in one of those things or more, concern for the individual, a knowledge informant, or the clinician that there has been a significant decline in cognitive function, and a substantial impairment in cognitive performance, preferably documented by standardized neuropsychological testing, or in its absence, another qualified clinical assessment. Continued, so B, the cognitive deficient interferes with independence in everyday activities. C, the cognitive deficient do not occur exclusively in the context of a delirium. The cognition defects are not better explained by another mental disorder. So here you also want to specify whether it's due to Alzheimer's, Lewy body disease, traumatic brain injury, prion disease, Parkinson's disease, Huntington's disease. And then you have a mild neurocognitive disorder. Evidence of a modest cognitive decline from a previous level of performance in one or more cognitive domains. So the same ones we mentioned earlier: complex attention, executive function, learning and memory, language, perceptual, motor, or social cognitive, based on concerns of the individual, a knowledgeable informant, or the clinician that there has been a mild decline in cognitive function, and a modest impairment in cognitive performance, preferably documented by standardized neuropsychological testing, or in its absence, another qualified clinical assessment. So continued, the cognitive deficiencies do not interfere with independence in everyday activities. So with prior one, it interferes with everyday activities. This one, it doesn't. So complex instrumental activities of daily living, such as paying bills or managing medications, are preserved, but greater effort compensation strategies and accommodation may be required. The cognitive deficiencies do not occur exclusively in context of delirium. The cognitive deficiencies are not better explained by another mental disorder. The statistics. There are an estimate of 4.6 million new cases of neurocognitive disorders each year. The number of people currently living with such disorder is expected to reach 135 million, up to the current 44 million cases by 2050. Alzheimer's accounts for 2/3 of cases of neurocognitive disorders. 17% of individuals with Alzheimer's also present with major depression. Typically, once Alzheimer's onsets, individuals only live for another 8 to 10 years. So, course and development, it is thought to be caused in part by buildup of beta-aluminoid proteins in the brain that cause a natural occurrence known as a senile plague. These plagues then result in neurofibrillary triangles that ultimately kill parts of the brain. Early onset versus late onset. That is genetic versus the environment. The key chemicals to observe appear to be acetylcholine and glutamate, as these are especially important for producing memory-linked proteins. So treatment options is drug therapy. Some drugs are prescribed after Alzheimer's has been developed and help to slow the decline or improve some issues with STM and reasoning. Other drugs may be taken before Alzheimer's to help prevent or delay the onset, including estrogen for women and possibly ibuprofen. Cognitive techniques is behavioral interventions, socio-cultural strategies, and caregiver support. Alternate lifestyles. The Beacon Hill Village in Boston is a community designed to provide resources and support to individuals over age 50 who aspire to maintain a level of independence and continue to reside in their own homes. It Takes a Village by Judy Willett. Beacon Hill Village celebrates 10 years. Okay, the big question. The majority of cases of Alzheimer's are only able to be 100% confirmed through a post-mortem examination of the brain. However, brain scans can be used to improve the confidence level with which physicians diagnose the disease in individuals. In some cases, these, along with family histories, can be used to predict the risk of eventually developing it. If there were a test that could tell you within 100% confidence that you were going to develop a disease for which there was no cure, would you take the test? So that's the big question they want to ask here. But that's it for this video. Thank you for watching.